Hello and welcome to So Now What with Gates Cambridge, a podcast tackling some of the world's wicked problems with those dedicated to doing something about them. I'm Catherine Galloway and my guests, as always, are Gates Cambridge scholars working to make an impact in the lives of others. In his end-of-year letter for 2023, Bill Gates quoted his old friend, the Swedish physician, Professor of Public Health and Statistics phenomenon Hans Rosling. Rosling, Gates reminded us, used to say, things can be bad and getting better. So, in 2024, Gates thought we'll be celebrating big strides on tough problems, such as Alzheimer's, obesity and sickle cell disease. Developments in AI could help us treat high-risk pregnancies, assess our risk for HIV, and make medical information easier to access. Channeling Rosling, Gates quotes one of his own favourite statistics, that since 2000, the world has halved the number of children who die before the age of 5. One reason is that vaccines have changed. Faster, cheaper, easier to deliver, even in the remotest areas of our planet. And a breakthrough in understanding our gut microbiome means we're incredibly close to tackling what Gates calls the greatest health inequity in the world, malnutrition. So we are undoubtedly getting better. But things are still pretty bad. Despite the devastating lessons of COVID, the world is not prepared for the next pandemic. Mental health is a universal human right, but many of the estimated 1 billion people worldwide who require support are not getting it. Life-saving drugs are all very well, but remain out of reach for the majority. And women and girls are endlessly the most left-behind patients of all. My guests today have already done in-depth diagnoses of these chronic conditions and join me now to ask, how do we make healthcare better for all? So, a very warm welcome to Joanna Reha, a member of the Gates Cambridge cohort of 2011, dialing in on Zoom from Kuala Lumpur, Malaysia, to Victor Roy, who first came to Cambridge on a Gates scholarship in 2009, returning in 2012 for his PhD, and he joins us today from New Haven in Connecticut, and to Sabrina Anjara, Gates Cambridge class of 2014 and the first Gates Cambridge scholar from Indonesia, who remains, at least for today, on Cambridge time, but is normally based in Dublin. Thank you all very much indeed for being here.
Thank you, Catherine.
Thanks, Catherine.
And thank you all for agreeing to take the temperature on how we are right now. It feels like the most impressive consulting room I've ever been in, quite honestly. Joanna, you're an epidemiologist working out how often diseases occur in different groups of people and why. That work has seen you leading teams in 7 different African nations, from Niger, Mozambique and Zambia to Uganda, Kenya, Somalia and South Africa. You've also worked in the UK as a policy director for the All-Party Parliamentary Group on Public Health. This included a project to raise the status of nurses worldwide. At Cambridge, you researched how radio and SMS messaging between publics and healthcare workers in Somalia might reduce the spread of cholera. And now you're a research lead at the UN's International Think Tank for Global Health, gathering and analysing the evidence for what really works as we try to address health and gender inequalities worldwide. Victor, you have a medical degree and a PhD, combining your skills as a family doctor and sociologist to examine the power of big money on big pharma and patient health. Your recent book, Capitalising a Cure: How Finance Controls the Price and Value of Medicines, zeroed in on the case of breakthrough treatments for hepatitis C and was published by the University of California Press in 2023. You are currently completing a postdoctoral fellowship in the National Clinicians Scholars Programme at Yale School of Medicine and also direct the Health and Political Economy Project, looking at the long-term effects of the racial wealth gap on health and well-being. In 2004, while still at university, you co-founded GlobeMed, a global network of undergraduate students and community organisations working together to tackle the challenges of poverty and poor health at source and forever. And Sabrina, you're a chartered psychologist whose research has included studies on the quality of life of female foreign domestic workers in Singapore, stress and personality types in applicants for medical schools, also in Singapore, and mental health provision in Indonesia, a country where only 1 in 20 people have access to treatment and where mental ill health remains deeply stigmatised. You're currently turning your attention to the virtual world as a research lead for Accenture's flagship global innovation hub, looking at everything from tech adoption in marginalised communities and diversity issues in pharmaceutical clinical trials to the benefits and risks of AI in the global south and even human interactions in the metaverse. So clearly, listening to all that, you are all incorrigible fixers, and we have a daunting body of issues to fix today. So let's begin by sharing the one thing that you're bringing to the table to help us. Joanna, let's start with you.
I think to kick us off, the one thing I'd like to bring is an example and an anecdote perhaps, and then a few statistics. I can't help myself as an epidemiologist. So if we were to think about a typical heart attack victim, many of us would often probably have, Victor, Sabrina maybe not, but a 60-year-old male in mind. And yet a woman is 10 times more likely to develop heart problems than breast cancer. And she's also more likely to experience treatment delays at all stages of care often. And somehow this is because heart disease is not considered or seen as a woman's issue or women's health problem. And women may present with symptoms that are often different to what doctors have been taught to diagnose with regards to cardiac symptoms. And so they're diagnosed much later or remain undertreated. And I think what this really boils down to, and where I would like to throw in some statistics perhaps, is that there's a lot of evidence that shows a clear gender gap with regards to ill health. So women are living more years in ill health and disability compared to men. And if we consider what that might mean, on scale, en masse, it roughly equates to 75 million years of life lost due to poor health. And that's roughly about 7 days per woman per year. This doesn't just extend to, the women's role with regards to access to healthcare, how they're diagnosed or treated, but it even affects decision-making with regards to their own healthcare. And again, we have a plethora of data available out there that shows that roughly 1 in 4 women still do not have the autonomy to make their own healthcare decisions. And this is not just kept in the realm of, healthcare delivery, but I think it's really important in these discussions we have with regards to making health better for all, that we recognize the role of women in the health workforce. And I think that's the part that perhaps is often forgotten or remissed. And so, again, some statistics, women are about 70% of the health workforce globally. That's a stat that's often thrown around quite a bit. But if we look at frontline health workers, who are often first responders, many of whom are nurses or midwives, they're about 90%. And we cannot forget the health of the health workforce if we're expecting them to be delivering health for all.
Thank you very much indeed for sharing that, Joanna, and for putting women front and centre of this discussion. Sabrina, what have you brought to the table today?
I would like to mention that in my field, which is mental health, and more recently, specifically AI, the effectiveness of AI models in diagnosing psychiatric illnesses range from 21%, pretty poor, to 100%, pretty hopeful. So that's quite reflective of where I am about AI as a tool that can help improve healthcare access.
Thank you very much, Sabrina. We're going to delve into that AI, good medicine versus bitter pill situation in just a moment. But Victor, I'd love to hear from you first, what you're bringing to the table today.
I'm bringing, I think, a sense of purpose around how we bring a conversation around the economy and its impacts on health. And of course, it's a big topic. But really, how do we build a more just and inclusive economy that provides people with the resources they need for health and dignity? And I think tying into both what Sabrina shared and Joanna shared, when we think about mental health, for example, we know that high levels of economic inequality in a country or in society actually lead to significant levels of distress and anxiety. When we think about the care workforce that Joanna just described, and there are many parts of the world where the economic policies don't really consider care work to be economically valuable, even though we know it's the infrastructure that actually supports all other forms of health and well-being in a home or in a community, in an economy. And so how do we actually economically value and value caregiving in a way that actually supports the women in those places that are providing this really important work and labor? That's the curiosity then that I have around, because it is a big question, like how do we do that? How do we build a more just and inclusive economy to support health and dignity for people?
Thank you very much indeed for putting caring and curiosity on the table as well, Victor. That is fantastic. I wouldn't be a very good doctor, if I didn't stop for a minute and take a quick family history. And I noticed that one thing that all three of you have in common is that you do have medical professionals in your families. So Sabrina, your mother, used to manage a number of hospitals across Indonesia. Victor, your grandfather was a family doctor and village health worker in West Bengal and seems to have been a real shining light in your own development. And Joanna, your father was a medical engineer working in numerous countries across Africa. So very quickly, before we dive into the other stuff, what is the one takeaway or the one lesson that you've learned from watching people in the medical field in your own families, and how has that influenced your work?
I can jump in. I think I've learned from watching my maternal grandfather. He was a village family doctor in the same village for over 60 years in a village about 4 hours west of Kolkata, in the eastern part of India. And I just say, it was a long-term commitment. A long-term commitment and relationships can drive change, but over a long, that can't be a transient thing. And so that's part of why I'm in family medicine, because it's about the relationships with families and my patients, and it's about being involved in these issues for the long haul.
Thank you, Victor. What about you, Sabrina?
I think two words came to mind: precision and compassion. Precision because sometimes what we say to people may be interpreted in ways that they want to hear rather than what we're actually saying. And so it's really important to be very clear. But that needs to be done with compassion as well, because sometimes when they're breaking bad news, the impact will be far-reaching, and most usually it's beyond just the person you're talking to, but their extended family, their social circle.
Thank you. And Joanna, what about you?
A few things. I think perseverance, and my dad left Europe as, a young 20-something-year-old, and actually started in Tanzania as a British volunteer with VSO, where he met my mom. So I think he's very committed, and commitment is something I really take away from his experience and dedication, but also a lot of humility and recognizing, his position as an Austrian in countries that are not his home, and being mindful of your position and your privilege, I think, is something he's always taught us and passed on to us in terms of me and my brother. But I also want to center my mother here, the non-medical profession, because I think, and being a mother myself of two young kids, the incredible work she did to bring us up and raise us in a way to be conscientious, thinking about others, recognizing the huge amount of work she did to be able to bring us where we are in our lives, is something I think we cannot stress enough. And it links to Victor's point about care work, whether it's formal or informal. But just something I really feel we should talk more about.
I think we should talk more about it right now, actually. This was a question that I was going to ask later, but, this idea of caring for the carers, the unpaid carers, which is very often the women of any family or community, the carers who are burning out and in very short supply globally, who are the medical professionals. We're also looking demographically at a rapidly aging population. 10% of humanity right now is over 65. So we're going to need more caring than ever before. We've just been through a pandemic. The results of that, or the impact of that, is still being felt. So let's put caring under the microscope right now. Give me one or two examples of how we can make healthcare better for everybody by making the caring better for our carers.
Ooh, one or two things. I think it's difficult to know where to start. I think if we think about the formal, there's the informal as well as formal, and if I were to stick to the formal for now, but if we look at the frontline health workforce and the violence they experience on a daily basis, and I think these are groups of the health workforce that are often forgotten. Community health workers that are somehow inside the system but outside the system, expected to work for free, very much underpaid, and I mentioned, gender pay gaps, but also undervalued. And if we think about, voices in leadership positions and decision-making tables, again, those are often the voices that are left out or excluded. And I think by integrating these voices in different decision-making platforms, whether they be globally, whether they be regionally and nationally, or within community settings, I think they will begin to advocate for the change that's needed. And one thing I just wanted to mention, Catherine, I think you've mentioned we're coming out of COVID, but also very much recognizing what lies ahead with regards to climate catastrophe, with regards to, Victor, if we look at, economic recession and constriction and what that means for a lot of families, but there's a clear gender gap with regards to poverty. So I think this sort of accumulation of crises, and the term polycrises keeps coming up yet, time and time again in humanitarian contexts. The care work and the role that often falls on women or girls with regards to caring for the sick, caring for the elderly, it often means they're neglecting their own health, and I think being mindful of that, is something, not a solution, but I think it's a starting point.
I know you published an article in the BMJ, Joanna, in March of this year on that necessity of, putting women's health front and centre in an era of polycrisis, because otherwise it will slip down the agenda. But Victor, as a family doctor, you're sort of front line. You are seeing the carers coming in, absolutely exhausted. What's the fix?
Absolutely. I see that in my clinic every day, whether it's, a family coming in with an elderly, with one of their elders who lives with them, and, they're expressing distress because they don't feel like they can let that person be alone in the kitchen anymore, right? And so now they're not sure if they can go to work because they're not sure if their father or their mother might end up, leaving the stove on and burning the house down because and causing harm to themselves. And so then that care issue becomes a well-being issue for the carer, also an economic issue for the family. There isn't one fix. There's a whole set of policies. I think government has to think about investment in huge ways, and really creating different kinds of, social welfare policies that happened 100 years ago. We need a whole new generation. One of the policies that I think isn't directly about care but would support it are policies like cash transfers and guaranteed income, because it would free people up to not have to be dependent on their role in the market. They could actually be at home if they needed to do care work in ways that would be more sustainable. In many of the instances, I see families who are working one or two jobs and doing the care work on top of all of that, right? And that's what, really brings people to the breaking point. And so we need economic policies that actually gives people agency to figure out how they can bring care into the mix of all the other responsibilities they have. So that's just like one idea. Of course, there needs to be others as well.
Thank you. And Sabrina, over and over again throughout So Now What, this first season, AI has come up again and again as this kind of magic cure for all sorts of things. But the guests have also been warning that if we don't get it right, it's going to be really problematic. Is there any way that AI could help the largest number of people in the most effective amount of time who are suffering this kind of care burden, or indeed a mental health burden as a result of caring?
Absolutely. So a few weeks ago, my team were looking at the idea of care robots, how AI, both in an agentic form or even as part of a toy, so a robot dog or something like that, can be used to alleviate the burden on carers. So this AI tool, whatever shape it takes, it can remind patients to take their medication. It can have a fall alert mechanism where an ambulance service will be called to the person's home in the event of a fall. And the idea is that it will take hundreds of hours of carers' time and return them back to the carers so that they can live their normal life. And understandably, this is an option for more wealthy societies. It's not one that is mass marketed so easily. And to your question about the largest amount of effect, we are seeing generative AI tools, so large language models, be one of the tools that truly democratize information to people. So I've been in conversations with people who have gotten mortgage advice from ChatGPT. I do not recommend that. And more people are getting their health information from the likes of ChatGPT. Now that is actually quite problematic because there is no regulation currently that determines the quality of the output that's produced by these tools. There are no safety standards that are in place at the moment. And of course, when we talk about AI, we can also talk about the more traditional AI models, which is predictive AI. My sister, she's a gastroenterologist. She does a lot of colonoscopies. She is using AI in her colonoscopies because it reduces misdetection by 50%. So when we want to talk about AI to help with access, to help with healthcare, what are we talking about specifically? I think the caution specifically about generative AI needs to be there front and center in people's mind. After all, large language models are probabilistic models. They're not designed to give you an accurate answer. They can't do what Victor does on a day-to-day basis. They can't come up with statistical analysis with precision and robustness the way Joanna does. All that still needs the experts.
Now, Victor, we have to get into the equity issue, right? We have to get into this now. And you've got something in common with Hans Rosling, who I quoted in my introduction. You've both taken on Big Pharma in relation to unfair and inequitable access to the new drug treatments available for hepatitis C. Rosling did that because he was diagnosed with it himself in the 80s. And when the new drugs became available in 2013, just as you were starting your PhD on that very subject in Cambridge, he took on the issue and called it a crime that not every hepatitis C patient everywhere had access to this medicine. So what is the prescription for fixing the treatment equity issue?
It's an important question. So, just in the quick context is these were curative treatments that were priced at $90,000. They became dubbed a $1,000 a day pill in the US. Many other countries also experienced pretty high prices. And we actually have some answers to the question because different countries took different approaches. And so in countries like Egypt and Australia, where the government came forward and said, we want to provide this for our entire population, they were able to negotiate ambitious deals with industry, or actually be able to say, we're not going to adopt the intellectual property protections in our country, and we're going to work with generic producers to bring these treatments closer to at cost, and that way provide it to our entire population. So they took a public health approach and have public health results. Both of those countries are on the path to eliminating hepatitis C in their countries, whereas a place like the US, for example, there's still 15,000 people a year dying in a high-income country because the government hasn't taken that kind of an approach. They've been more, I would argue, laissez-faire with the pharmaceutical sector, and as a result, don't have the incentives to go and diagnose. The health systems aren't going out there and trying to find those patients because it's seen as a cost rather than as an investment in the health of those people. So I think a lot of it has to do, the Hep C case study is a broader case study for, the relationship and the dynamic between the public and the private. And are we actually building symbiotic public-private partnerships, or are we engaged in more parasitic public-private relationships that don't end up actually directing our resources towards health?
Thank you. I mean, do you get the sense that Big Pharma is remotely listening to this argument?
I think what's probably most important is that publics need to be engaged in this argument, because businesses won't ever do anything on their own accord because somebody shamed them, right? It actually ends up requiring governments and citizen action to hold corporations and other actors accountable. So that's where I would place the emphasis, rather than trying to convince a C-suite person.
Very interesting. And Joanna, if we stay on the topic of actual cost and economic, just the maths of healthcare for a minute, you're arguing that, investing in women and girls' health is not just a good idea from a medical or a humanitarian point of view, but actually it makes economic, social, political, climate sense to do so. What are the most effective ways that you have found so far to make that investment, to make that pay as quickly as possible for the largest number of people?
The greatest return, investing perhaps in feminist civil society organizations who are working at the grassroots, who understand a lot of the issues, and I think they're often the ones, who experience cuts in funding first. They're the ones who are going to be advocating for some of the things Victor's talking about, And if we think about, COVID and the TRIPS waiver, and I mean, these issues are happening at national level, as Victor has described, but also at global level. And, a lot of countries are in debt, and debt increases due to rising inflation and interest rates. And they're crippled, and governments cannot invest in the health systems as they would like to. I think, as Victor highlighted, the role of the legal systems and structures that are put in place that limit this. So I would say investing first and foremost in strengthening civil society organizations that are working with communities to demand for their needs and rights with regards to health is critical. But really tackling financial responses to global crises as well from a gendered lens. And I mean, one of the points I wanted to make, Catherine, I know my answers are not short, is that, when we talk about women, it's women in all their diversity, but also it's not a monolith, It's not one group of people. If we look at the gender poverty gap, it's women who are living on, $2 a day. Those are the women who are the majority, who are experiencing a lot of the inequities that we're talking about and are most impacted. So we need to really position it with that lens and think about who's being left behind.
And it wasn't so very long ago, 2021, that Scotland was the first country to give free access to all menstrual products to any women or girl who needed them. And that's since spread to 15 other regions at least, from Botswana to New Zealand. Obviously, that shows the power of a single change, which then spreads and addresses a much greater global health inequality, in this case, period poverty. But Sabrina, surely the biggest impact comes from connecting what the grassroots campaigners want and need with what huge corporations could deliver at scale. So how could AI help with that?
There are two ways that we can look at it structurally. So we're looking at big pharma, tech companies and all that as a top-down system of power where they own power because they have a lot of money, capital, relationship with governments and things like that. Then how AI can be used to impact their decisions will be quite different to how grassroots organizations can be empowered to be part of the conversation. Because oftentimes, as Joanna said, yes, CSOs, local CSOs, they're the best investment because they work with the local communities. But the problem is sometimes they don't get that access to funding. Sometimes they're not invited to the party. On the flip side, now that I've seen how industry operates, industry actually wants to have that partnership. But sometimes they just don't know how to have that partnership in a way that doesn't sound like lobbying, in a way that doesn't get them into trouble. So I think AI probably can be used in coming up with the data that is useful for the purpose, because honestly there's a lot of stats being thrown around that doesn't mean very much for decision making.
Thank you very much indeed, Sabrina. To my horror, we have to almost wrap it here, but I wanted to finish with a quote from a journalist that I like very much, Nicholas Kristof. He's with the New York Times. He's won the Pulitzer Prize twice. He's a pioneer of solutions journalism, which is a kind of journalism I'm very interested in and motivated by myself. And I came across something that he said recently, which is, I've always been interested in public health approaches because it seems to me we have this yearning for silver bullets. And I'm guilty of that in the questions that I've asked you today, right? And that is not, he says, in fact, how change comes about. Change comes through silver buckshot, a lot of little things that achieve results. And he says that's a classic public health approach. So if we were to finish by asking, so now what? Could you give me some silver buckshot that we could take away and use today?
Well, I would tell people, one will be a shameless plug to check out this initiative that I'm building with Derek Hamilton, economist at the New School, and Dave Chucksey, who's the former health commissioner for the city of New York, called the Health and Political Economy Project. You can Google it, and right now it's based at the New School. And one of the things we're working together to think through is kind of an agenda of, I guess we could say, silver buckshots that are about economic policies that would support health. And so you can check out kind of an agenda of some of those ideas on the website, but everything from baby bonds, which are a policy that would guarantee an inheritance for young adults at the age of 18, and what that would actually do for people's ability to control resources that are important for their future health, to thinking about public options in our economy. So actually, for example, public production of pharmaceuticals as something we need to be actively and proactively and purposefully thinking about, that would give and guarantee access to our most essential medicines. So those are just two examples of economic policies. We need a whole agenda of them, and to move from what we see as kind of a gilded age in our economy to a more equitable future.
Thank you, Victor. What about you, Joanna?
I think two pieces. One will be a plug also. But I think on an individual level, a lot of the issues we've talked about with regards to, how we make healthcare better for all are actually perpetuated by social norms, social stereotypes that we all consciously or unconsciously inhabit and behave, through or with. And I think that's a really critical point, is that all of us in, whatever institution we're working in, whether it's directly related to the health sector or not, impacts the health of colleagues, impacts the health of our families at home. And so being conscious of some of these biases or stereotypes that actually harm others, and not speaking out or not trying to heal oneself with regards to some of these issues, I think is a starting point. And I think linked to this, if you want to find out more about some of the work that I'm doing, in particular at the United Nations University International Institute for Global Health, I've done a podcast series looking at the power of and the role of feminist leadership and deep structures within organizations, looking at the role of collaboration and what that means, looking at the power of evidence, the power of feminist civil society organizations, the power of institutional structures. So I would encourage people to listen to the podcast to find out more. It's not just me talking, it's a lot of experts as well in the field more broadly. So yeah, and it's called it's The Power Of, with a mini-series.
The Power Of. Oh, we love a podcast plug here on So Now What? And thank you. I will certainly go and check that out. And Sabrina, finally, what are you going to leave us with? Give us some silver buckshot too.
Never stop asking why. I learned that from my 3.5-year-old. And probably the first why that you should be asking today is, why are rich countries rich? How did they become wealthy? The second why question maybe could be, why are pre-industrial variables such as gender, race, religion continue even 100 years after industrialization to be the cause for inequality in our current world?
I love that. Those are two terrific why questions, and it's not just 3.5-year-olds everywhere that should be asking them. Thank you very much indeed, and that's it for this episode. So huge thanks to my guests today. Joanna Reher, Research Lead for the Gender Equality and Intersectionality Work Package at the United Nations University's International Institute for Global Health, and that's in Kuala Lumpur in Malaysia. Victor Roy, family physician, sociologist and postdoctoral research fellow in the National Clinicians Scholars Programme at Yale University in the United States, although we should mention, Victor, that you're soon off to the University of Pennsylvania to begin work as an assistant professor of family medicine and community health, so all the very best of luck with that. And finally, chartered psychologist Sabrina Anjara, lead of the digital humanity research at Accenture's Human Sciences Studio at the Dock in Dublin, Ireland. I hope all of our listeners feel very much better after hearing you today. I certainly do. My thanks too to producers Mandy Garner from Gates Cambridge and Nick Saffel from the Central Communications Office at the University of Cambridge. I'm Catherine Galloway, and this was So Now What with Gates Cambridge, and it's also our last episode for Season 1. We've examined 8 wicked problems with 24 incredible guests, and there's more to come shortly when we sit down again for Season 2. In the meantime, catch up with any you've missed so far, wherever you get your podcasts. Thank you for listening.